Hello everyone, good evening. Welcome to the image-based session for the cornea, and thank you so much. I got your valuable feedback about the conjunctiva image-based session, and I'm happy that it helped you a lot and you people liked it. So, continuing with this image-based session for specially designed for the FMG students, this is your cornea image-based session. So, there's a question that will you continue the series for the other topics? Definitely, why not? Because I want you people to revise the topics, and I think image based discussion is a discussion that is very fruitful for not only for the image based questions but also kind of mini revision. And whenever we are revising with the help of images, it becomes slightly easier for us to recall also, and we are also revising all the important previous year questions and the awaited questions that are expected in the coming FMG examination, right? If you have any other suggestion, because your feedback is always welcome and it's very very valuable for us, so please comment in the live chat section that what other things you would like to have before the examination, as your examination is very very near. So whatever you feel like that we can have more in order to have good revision, please tell me definitely, right? So shall we start? Is my audio video clear, guys? Let me know if my audio video is clear, good enough, so that we can start. Okay. So starting with the cornea. Success. Very good. I like the name and wish you all the very best as per your name. Hi Alok. Thank you. So cornea image based session. Now as you know that if you go by the cornea, a very very important thing about cornea is that cornea is avascular, right? Cornea is avascular. It is transparent. These are the one-liner kind of questions that are important. Now though previously your paper consisted of majority of one-liners, but now you are having some one-liners and some clinical questions, so I'll try to cover both of them. So it is avascular, it is transparent, and it consists of anterior 1/6 of the fibrous coat. Okay? It consists of the anterior 1/6 of the fibrous coat. What is the posterior 5/6 part? Who is going to tell this? The posterior 5/6 part is your sclera, and a very very important thing is that what is the junction? The junction between the cornea and the sclera is called as, if you look at the cornea and the sclera, so this junction is called as the limbus. Very very important is your limbus, right? So these are the important things regarding the cornea to start with. I think this everyone knows. Alright. Now, if you look at the shape of the cornea, we'll discuss the shape as well as dimensions, and then we will come over the layers directly. See, if you look at the time of the birth, yes. So, if you look at the time of birth, the cornea is actually spherical. Cornea is spherical and its dimension is 10 mm. Okay. While if you look in the adults, it is actually elliptical. It is elliptical in shape, and the dimension will be 11.7 into the 11 mm. So this is the difference in the shape and the size if you consider it at the time of birth, because it is spherical, so it is having equal diameters. Okay, but in the adults it is elliptical, so we are having 11.7 into 11. Roughly you can also remember it as 12 by 11 mm. Now what is the age by which we are getting this adult dimensions? It is by 2 years. Third important thing, it is by 2 years. One thing more, guys, I know that in the end you ask for PDF, and I'll try to share that also, but I will definitely recommend that you should write these notes yourself in a separate notebook, so that when you revise the ophthalmology, before that you can open up, because whatever things you are writing in your own handwriting are always more beneficial, far more better than any PDF or any handwritten note. So I will definitely recommend that you can note it. I am writing. This is 1 hour session running. Okay. So I will definitely recommend that please write it in your own language. I am not writing many long notes. They are just the short and the crisp notes. Okay. So please try to write it by yourself. Now, okay. Now another very important thing, see this, is your layers of the cornea. Now previously there were 5 layers of the cornea. Now we have 6 layers of the cornea. I think this is the beauty of this session, that just in 1 hour you are going to revise every bit of one topic. Everything. PYQs also, one-liners also, clinical questions also, image-based questions also, and mini revision of all the things. So just in 1 hour. So 5 layers were before, but now we have got 6 layers. It is A. A first is your anterior epithelium. First is then this. Then we have got B. B for Bowman's layer. Then we have C. C is for connective tissue. Connective tissue stroma. Okay. Then we have got D. Now D say we have got 2 things. D for Duas layer, and we have got D for your Desmond's layer also. D for Duas layer, D for Desmond's also, and then E for endothelium. So just the 5 alphabets A, B, C, D and E, and you are done with the layers of the cornea. I'll write it for you here. A, B, C, D and then we have E. So try to memorize it. Here only we have got A for anterior epithelium. Okay, A for anterior epithelium. Now you will tell me, please write it in the comment section. What is the type of epithelium here? Another important question. B for Bowman's membrane. B for Bowman's membrane. Then we have C. C for connective tissue stroma. C for connective tissue stroma. D for Duas layer. Then we have D for Descendant membrane, and E for endothelium. E for endothelium. So these are the 5 layers, 6 layers which you can easily memorize. So continue for all topics. Yes, I'll definitely try to continue it for all the topics. Okay, don't worry. Very good. So everybody is given the right answer. So first important thing is the type of epithelium. Non-keratinized. Non-keratinized, stratified. Squamous epithelium. One important question is the type of epithelium. Okay. Then we come to the Bowman's membrane. Now Bowman's membrane is a layer which is acellular. Another important question, because you get a lot of questions related to the layers. So whenever you are discussing the layers, we will be discussing all the important questions related to it. Bowman's membrane is acellular. Why it is acellular? Because it is actually the superficial condensation. It is the superficial condensation of the stroma part. So it is not having any cells, just the stroma is condensed superficially and it forms your acellular layer. It is the condensation. So what is important about it? Therefore cannot regenerate. Therefore, it cannot regenerate. 3 important questions. What is the type of epithelium ho gaya? Bauman's layer is acellular. Keep on learning, guys. Then we have superficial condensation of stroma. It is acellular, does not have any cells, and therefore it cannot regenerate. Okay? Written. Now come to the connective tissue stroma. When I say stroma, obviously it will be the thickest part. So this will be the part having the maximum thickness. Another important question, which is the part which is having the maximum corneal thickness? Maximum corneal thickness is stroma. That means if the bacteria has crossed the stroma, the chances of perforation will be very, very high. Okay? Now coming to Duas layer. Now this is your newly discovered membrane, new membrane, newly discovered hai. This is newly discovered, and what is important about it? It is 16 microns thick, and now it is the toughest layer. Now it is the toughest layer. Means earlier actually Descemet's membrane was considered to be the toughest layer, but according to the present scenario, if they ask you the toughest layer, your answer will be Duas layer. It is also called as the pre-Descemet's layer, right? Now, if you talk about the Descemet's membrane, it is a very, very important. Very, very, very. Why? Because Descemet's membrane is a membrane which can regenerate. It is a membrane which can. This is just for learning. Then we have acellular hai, cells nahi hai, therefore it cannot regenerate. Because it cannot regenerate, it is bowing his head. Okay? Why it is acellular and cannot regenerate? Because it is just the condensation of the stroma. And then we have the stroma, obviously the thickest part. Then we have pre-Descemet's membrane, the newly discovered membrane. Then we have a Descemet's membrane, which is very, very important. It can regenerate. Then we also have the Schwalbe's line. What is Schwalbe's line? Anybody? Schwalbe's line is again a MCQ in itself. It is the prominent end of the Descemet's membrane. Prominent end of the Descemet membrane of the cornea. It is the prominent end of the Descemet's membrane of the cornea. So this is actually a part of angle of anterior chamber. A part of angle of anterior chamber. And then it also forms the desmetocele. Desmetocele actually we will be discussing in the bacterial corneal ulcer. So I am not talking about it because we will be discussing this in the bacterial corneal ulcer. Good evening. Hi everyone. Welcome to the session. I hope you people are learning. So again, important thing. And finally, we have endothelium. Now, endothelium is the powerhouse of the cornea. So, it is most important because it is metabolically active. It is metabolically active layer. Which layer is metabolically active? It is actually the endothelium which is metabolically active, and that is why I am concerned about the cells. So how they actually look like, let me show you how the endothelial cells look like. See this. So how can we see? First of all, if I want to see the endothelial cells, whenever you want to see the endothelial cells, whenever you want to see the endothelial cells, we do the specular. Another important question. Guys, please keep on remembering and noting. This is called as specular microscopy. So, one important thing is your specular microscopy. Can you see the shape of the cells? Come on, who will tell me what is the shape of the cells you are seeing? The shape of the cells that you are seeing here is very, very important. Yes, very good. Dr. DS, Ashti, Pearly Shine. Wow, what are the names? Success and Pearly Shine, right? So, yes, it is the specular microscopy, and you can see the shape of the cells is hexagonal here. So, the shape of the cells that you are getting on the specular microscopy is actually hexagonal. Another important thing is The shape of the cells is actually hexagonal cells, and if you look at the count, it is 2000 to 3000 cells per millimeter square. So endothelial cells are metabolically active cells. They are responsible for transparency. They are seen by specular microscopy. Then if you look at the shape of the cells, and then we have the count of the cells. These are the important things. So why am I so concerned about the endothelial cells? Because if I am doing the corneal transplantation, if I am giving a cornea to somebody, I will definitely check the number of endothelial cells in this person, because if the cells are less than 500, if the cells are less than 500, then there will be corneal decompensation. Then it will be corneal decompensation. It is very, very important. So whenever we have less number of cells, less than 500, there will be actually corneal decompensation. So it is actually very, very important to do this test before your corneal transplantation. So layers of the cornea we have done. Now anybody who can tell me the answer of this question, which layer helps in maintaining the hydration of the stroma of the cornea? Yes. So who will tell me the answer of this question? Which layer? We have learned about the layers. Which layer of the cornea helps in maintaining the hydration? 30 seconds. Is it the Descemet's membrane? Is it the endothelium, epithelium, or the stroma? So please answer. Help me answer this question. Which layer will help in maintaining the hydration? So all these are your PYQs, very, very important and expected to come further also. Yes, so it is actually the endothelium, because it contains the sodium potassium pump. Because it contains the sodium potassium pump, therefore it is metabolically active, most vital layer also. It is also called as the most vital layer. It is all Rajat, it is not D. It is actually B, endothelium, most vital layer. It is the most vital layer of the cornea, responsible for maintaining the transparency. So we have done all the question related to the layers. Okay? Now we will come to the ulcers. So let us talk about a very, very important ulcer. Which one is your most important ulcer? The bacterial corneal ulcer. And whenever you have the bacterial corneal ulcer, something like this you are going to find. So let us talk about a clinical scenario of the bacterial keratitis. A very, very important is your bacterial keratitis. Okay? So whenever you get a question on the bacterial keratitis, या फिर you can call it as acute bacterial corneal ulcer also, you will get a question on acute red eye. You will get something like acute red eye. Let me zoom it out. Yeah. So you will get a question on the acute red eye. So can you see this patient will actually present with the sudden painful diminution of vision. So first of all, what will be the DD of this patient? If I am having a patient having this acute red eye who is having sudden painful diminution of vision, red, fiery red appearance, can you see this kind of picture? What are the things you can consider in this patient? Because sometimes all the 4 options are given in the answer and you do not know how to actually rule out. Everybody knows the characteristics of bacterial corneal ulcer. So my interest is not to tell you the characteristics. My interest is to tell you how to differentiate it from other ulcers and how to differentiate it from the DD of acute red eye. So we can have acute anterior uveitis. Okay? It can be a DD in the form of acute anterior uveitis. I can also have acute congestive. We can also have acute congestive glaucoma. Can you see in the definition itself, in the name itself, the acute word is written. It is acute anterior uveitis, acute congestive glaucoma, then acute bacterial keratitis. Of course, we can have the chemical injuries. Chemical injuries are also there. उसके अलावा what are the things you are having? Can you see lot of vascularization? So whenever you are having the acute red eye, you have lot of vascularization. Plus, whenever we have the bacterial response, okay, whenever I will have this bacterial infection, what is the most common thing you will have? That is pure pathology. You will have the lymphocytic infiltration. You will have the lymphocytic infiltration. Now try to understand, if I have the vascularization, if I have this vascularization and I have lymphocytes also, then obviously it can go deeper and deeper. Yes or no? Now because it can go deeper and deeper, therefore the chances of perforation are very, very high. Chances of perforation are very, very high. This is a simple, logic behind the bacterial ulcer. Bacterial ulcer mein you have lot of redness, lot of vascularization, lot of lymphocytes that due to the response due to bacteria. Now, if I have lot of lymphocytes, I will have lot of exudates. ठीक है ना? I will have lot of exudates, and if these exudates are going in the anterior chamber, always remember the story of thirsty crow. ठीक है? What will happen? The pebbles will settle down and water will come up. So if I have lot of lymphocytes in the anterior chamber, these lymphocytes will settle at the bottom and aqueous humor will come up. So these pus cells or the lymphocytes which are settling down, that will form the hypopion. That will form the hypopion. So this is how actually we are having the perforation, we are having hypopion, we are having vascularization. These are the common words that you are going to get in cases of bacterial corneal ulcer. Now who will tell me the two characteristic features of bacterial corneal ulcer? Very good, very good. Amazing guys. Motile hypopion, sterile hypopion. Very good. So there are two characteristic features of this hypopion whenever we have bacterial hypopion. Exactly correct. It is always sterile and always mobile. Very, very important. Now these are the two important characteristics that we are going to have in the cases of bacterial ulcer, because they have no hyphae. Now because they have no hyphae, therefore no invasion. No hyphae, no invasion. So they are not penetrating deep inside. Because they are not having any hyphae, there is no penetration. Therefore it is not fixed, and it is not the unsterile also. Because the exudates are there, these are the lymphocytes, but the bacteria are not going, so it is sterile, and because there is no invasion, so it is mobile. So always remember that the bacterial hypopions are always sterile and always mobile. So that means if I am having exudation in the anterior chamber, try to understand it with the help of a picture. Suppose this is the cornea here. These are the 6 layers of the cornea. Okay? Now in this cornea, we are having this iris, ciliary body and lens of course, and this is the posterior part. And we also know that this portion will contain the aqueous humor, something like this and something like this, right? It is there. Now if I am having penetration from the bacteria, so first of all it will go to the epithelium. This is the epithelium. Then it will go to the Bowman's membrane. This will be the Bowman's membrane. Then we will have the stroma. So stroma is the thickest part, and I'm making it same color as that of the Bowman's membrane, because Bowman's membrane is the condensation of the stroma only, like this. Then making it quite thick, we will have the predesmens membrane. then we will have the Descemet's membrane, and then we will have the endothelium also. This will be the endothelium. Okay, like this. So this will be Bowman's membrane. This is the stroma here, and then Duas layer, Descemet membrane, and endothelium. You have already learned about the 6 layers. Now, if the bacteria is going deep, it can be actually sealed only at the level of this Descemet's membrane. So Descemet's membrane only has this property to actually make the cavity and prevent itself from going inside. So this Descemet membrane forms the descemetocele. This forms the descemetocele. Descemetocele means herniation, a cavity kind of thing is formed. So this herniation is there, a cavity kind of a thing is formed, which is preventing the perforation. So this is your impending perforation. So this is leading to the impending perforation. Yes, if I am having problems even at this, then it will lead to the perforation. So that is actually the quality of Descemet's membrane, impending perforation. So whenever I really thank you for all, but I do not know how much portion of the cornea I will be able to cover. Let's see. And don't worry, if I am not able to cover whole of the cornea today, we will carry it forward, okay, next time also. Yes, so this is your Descemet's membrane. Now we are going inside and we are having the exudation in the anterior chamber, right? So these are your aqueous cells, exudates are there, and therefore we will have inflammation in this iris as well as this ciliary body. Now see this very carefully. If I am having inflammation in this iris as well as ciliary body, together what is it is forming? Iris and ciliary body inflammation, what it is called as? Iridocyclitis. This is forming iridoencephalitis. Iridocyclitis matlab acute anterior uveitis. So bacterial keratitis can lead to anterior uveitis. That is why I have photophobia also. I have hypopyon also. All those features of acute anterior uveitis I am having here. So a lot of exudates, and these exudates will settle at the bottom, and this is actually forming the hypopyon. So basically, what is the concept of bacterial ulcer? Why I am having redness? Why I am having photophobia? Why I am having hypopyon? Why we can have perforation? Why the chances of perforation are very, very high in the bacterial ulcer? How will this patient present? Sudden painful? Is it very, very clear to everyone, guys? Because just opposite to this will be your fungal corneal ulcer. So if you have got this picture, now we can move on to fungal corneal ulcer. I will show you one question also regarding this. See this, guys. Can you see this? Descemet's membrane can yes, Descemet's membrane can regenerate. Descemet's membrane and endothelium are the separate layers, and Descemet's membrane can regenerate. Okay? Now see this question. I told you we'll be doing a lot of questions. So see this, a 70 years old lady following the cataract surgery. Yes, Descemet's membrane is the secretions. The cells of the Descemet's membrane, half is actually the fetal layer which is already present, and half one is the adult layer which is secreted by the endothelial cells also. So you are correct in that way. Okay. Yeah. So can you see we have a 70 years old lady, a clinical scenario kind of question, 2 days following the cataract surgery. It is 2 days following the cataract surgery. and presenting with the eye complaints. What is the answer? Anybody, guys? Guttae are found in the endothelial. Yes. Cornea guttata. They are found in endothelium. So what will be the answer? Can you see here? This is the hypopion. So because it is a hypopion, right? So you can see this is a case of the bacterial. Yes, bacterial infection. After the cataract surgery, which is common, we have bacterial endophthalmitis, right? So we are suspecting the bacterial endophthalmitis in this patient. So what you are going to do? Will I give steroids? Obviously no. Infection hai, no dressing, no patching. Mannitol we give in the acute congestive glaucoma. So not this. So answer will be your intravitreal antibiotic. See this. Answer will be your intravitreal antibiotic. So this is how you can get a clinical scenario also over this. Alright. Now we will try to see a different kind of ulcer. Can you see this? We are having a large ulcer and we are having the smaller ulcers also. So basically what you are seeing is, dry looking. This is a dry looking ulcer. It is grayish white. Dry looking hai, grayish white hai. Then you can see these are your multiple satellite lesions. Multiple satellite lesions. Dry looking hai, grayish white hai, multiple satellite lesions hai, and we have no vascularization. So these are the properties of the fungal corneal ulcer, where a very, very important thing is, always remember, signs are always much more than the symptoms. The signs are always much more. Many a times patient even does not know that he or she is having the fungal ulcer. So bilkul ulta hai of the fungal corneal ulcer. Fungal corneal ulcer is like chow. I am having lot of pain, lot of photophobia, acute redness, and lot of vascularization. While fungal is silent killer, dry looking, grayish, and because it has got hyphae. Because of the hyphae, it is having the multiple satellite lesions. Finger-like processes are there. That is also there. We have lot of finger-like processes because of the hyphae, and because it has got the hyphae, these finger-like processes will be entering the hypopion. So what kind of hypopion I will have here? Therefore, the hypopion that is found in the fungal corneal ulcer is non-sterile. It will be non-sterile because hyphae is going into the ulcer, and also it is non-mobile, non-sterile and non-mobile. Can you see how much opposite it is of the bacterial ulcer? You must have seen, some of the family members, one is very, very loud, and whenever he or she experiences even little amount of some trauma, they will, make loud announcement. So bacterial corneal ulcer is something like this, but some people are very, very patient, and even if they get something major, they say nothing. So silent kind of people, and that is your fungal corneal ulcer. फंगल कॉर्नियल अल्सर में ड्राई लुकिंग है, ग्रेइश वाइट है, सैटेलाइट लीजन्स हैं, फिंगर लाइक प्रोसेसेस है, मोर साइंस हैं, वैस्कुलराइजेशन एब्सेंट है, वाइट-ish आई हो रही है, एंड साइंस आर ऑलवेज मोर देन दी सिम्टम्स. देन अनदर important thing is, see this, you will have the feathery margins. You will have the feathery margins. These are all the important features of fungal corneal ulcer. Who will tell me the etiology of fungal corneal ulcer? Very good. Non-sterile, non-motile, feathery, rolled out margins. What is the most common etiology? Always remember, it is the injury with the vegetative matter. Injury with the vegetative matter is the most common etiology. The most common etiology that you are having in the cases of fungal corneal ulcer is the injury with the vegetative matter. Name of the fungus. What is the most common fungus we are having? The filamentous fungus. It is the filamentous fungus, more common than the yeast-like fungus. Filamentous fungus is more common than the yeast-like fungus, and in the filamentous I will have two. One is your aspergillus, and this is more common than the fusarium. Aspergillus more common than the fusarium. In the filamentous fungus, most common is aspergillus more common than fusarium. So I think fungal corneal ulcer is very very clear. सबको clear है. Aspergillus is there, but aspergillus is not the most common one. Aspergillus is the most common one, sorry. And out of the two, aspergillus is followed by your fusarium. And out of the filamentous and the yeast-like, it is the filamentous which is most common. Now, if they are asking you the treatment, we have got the different. Aspergillus mein we will give the netamycin. So, if they are asking you treatment and they are giving you the etiology, plus we will have the nystatin. Nystatin is there. Okay? So, this is your fungal corneal ulcer. I think you have understood the difference between the bacterial and fungal. Again, I will say I am not interested in just in telling the characteristics of bacterial and fungal. Differentiation is more important because in the question you will have to differentiate. Clear hai? Let us move towards the third one. Yeah. And I think this is a must for every FMG exam. Must. And I will write FMGE. FMGE 2022 because most of the time this question will come. So whenever I am talking about the viral ulcers, okay? Whenever I am talking about viral ulcers, that means I am talking about herpes. And whenever I am talking about herpes, we have got two types, herpes simplex and herpes zoster. Now I will tell you a very simple trick. ठीक है, सिंप्लेक्स मतलब है सिंपल, दिस इज सिंपल, एंड जोस्टर मतलब इट इज सीवियर. ठीक है, वन इज सिंपल, वन इज सीवियर. सो सिंप्लेक्स इज सिंपल मीन्स नो सिस्टमिक फीचर्स, जोस्टर इज सीवियर, सो कॉजिंग लॉट ऑफ फीचर्स, सिस्टमिक फीचर्स भी. नाउ व्हेन आई टॉक अबाउट सिंप्लेक्स, यू हैव टू रिमेंबर दिस image. This has come in your exam so many times. So this is your PYQ. Oh, बहुत zoom रखा है. This is your FMGE PYQ. Very very important. This is the typical dendritic ulcers. Dendritic ulcers, very very important characteristic of herpes simplex. ठीक है. Now there are certain important things how they look like. So we have the tree like arborizing pattern. इस तरह से होगा with the knobs also. Very very important is your knobs. So these are the knobs here, and this is the floor. Always remember that if you are getting such kind of pattern, it is the dendritic ulcer, important for the herpes simplex. Always remember, okay? And if you are having knobs, these are always the true dendrites, because if you are not having any knobs, they will be the pseudo dendritic, okay? So herpes simplex mein you get true dendrites. Now if you look at the stain, floor, F for F is stained by the fluorescein. It is the fluorescein stain, and the knobs by rose Bengal stain. Now who is going to tell me the treatment of this herpes simplex keratitis, dendritic keratitis specifically? Candida will also cause same type. Candida भी fungal है, so all the characteristic features of the fungal will apply to the candida. Also your Hi, Dr. DS. My review book of ophthalmology will be available very, very soon. So you have to wait for some time. Yes. So definitely because it is viral. So what we are going to give 3% acyclovir. ठीक है? We are going to give 3% acyclovir. वायरल है तो यू हैव टू गिव एंटीवायरल. लेकिन उससे भी ज्यादा इंपॉर्टेंट इज दैट यू नो स्टीरॉइड्स आर कॉन्ट्राइंडिकेटेड. ट्रीटमेंट से भी ज्यादा इंपॉर्टेंट क्या है? व्हाट इज कॉन्ट्राइंडिकेटेड? नेवर गिव स्टीरॉइड्स whenever we have dendritic keratitis. Why? See, this will happen. There will be collision of all these ulcers. Large ulcer will be formed. And what is this large ulcer called as? It is called as the geographical ulcer. This is called as the geographical or amoeboid ulcer. This is called as geographical ulcer or the amoeboid ulcer. तो सबसे पहले dendritic keratitis is the characteristic of herpes simplex. Tree like arborizing pattern था. Look here. And we were having the floor and we were having the knobs. Floor की staining is by fluorescein. Knobs की staining is by the rose bengal. ठीक है, वो clear हो गया. Then we have to come to the treatment part. Treatment में you are giving the 3% acyclovir. And what you don't have to give is the steroids because you will have the geographical ulcer or the amoeboid ulcer. अभी clear है? ठीक है? Now the more खतरनाक one, the more severe one is this. A very, very important picture. Who will tell me what is this? Again, very, very important picture for you guys. Dr. DS, you are absolutely correct because it hastens to form the geographical ulcer. That is why we are not giving the steroids. Now, what is this? Now, can you see here? This is the frontal division. This is the lacrimal division and this is the nasociliary division. So, when I talk about the herpes zoster ophthalmicus, right? Herpes zoster ophthalmicus, it involves the ophthalmic division of the trigeminal nerve. Ophthalmic के you have got 3: frontal, lacrimal and nasociliary. So when all these 3 divisions are involved, then this is a case of herpes zoster. Very, very easy to identify. Strict distribution on one side of the forehead, है ना? Strict distribution है, all 3 are involved है. And a rule which is very, very important is your Hutcheson rule. So many a times this Hutcheson rule is also asked. That means what? If you are getting the eruptions on the tip of the nose or the side of the nose, that means your nasociliary division is involved. So that means the chances of eye involvement are very, very high because it is first the frontal division, then the lacrimal division and then the nasociliary division. So if I am having eruptions in the tip of the nose or the side of the nose, the chances of your lacrimal involvement are very, very high. Very, very important. ठीक है? And the important thing is this. ये देखो, what is this? Can you see here I am not having knobs, no knobs, but I am having the dendritic pattern but no knobs. So this is your pseudodendrites. Another important thing are pseudodendrites. Another important thing is pseudo. Pseudo means false because there are no knobs. Can you see? There are no knobs. So because I am not having knobs, it is pseudodendritic pattern, and pseudodendrites are found in herpes zoster, while the true dendrites are found in herpes simplex. This is found in herpes zoster. Now, like the dendritic keratitis was characteristic of herpes simplex, what is characteristic of herpes zoster? Anybody? What is characteristic of herpes zoster? म्यूकोरमाइकोसिस तो बहुत डिफरेंट हो जाएगा. आई थिंक म्यूकोरमाइकोसिस I do not have the picture right now, but another session I will show you the mucormycosis also. Mucormycosis will be blackish in color now. This is, you are seeing in the fluorescent staining, and which filter we are using? The cobalt blue filter. Plus when you talk yes, true person, simple person, yes, is the herpes simplex. The name of the filter is your cobalt blue filter. दूसरी बात, if you look at the risk factors, mucormycosis is occurring in the patients who are having lot of immunodeficiency. So chronic diabetics हैं, COVID patients हैं, immunocompromised हैं, neutropenias हैं, lot of blood transfusions, hematochromatosis, patients on steroids. All these patients are having the mucormycosis. And the route of entry will be different. It will be from the nose or from the eye, so it will be an entirely different picture. And there you will have the angio invasion in the mucormycosis. If I talk about the mucormycosis, there you will have the angio invasion. In the angio invasion, so there you will have the ischar formation, a very very important thing, blackish area, ischar formation will be there. Okay? Yeah, so I asked you what is the characteristic feature of herpes zoster. So it is these small coin like areas, when you are having these, or the disciform areas. This is called as nummular keratitis. This is actually characteristic of herpes zoster. So एक तो था bacterial, lot of inflammation, lot of vascularization, lymphocytic infiltration. Then एक silent था, that was your fungal, feathery margins, finger-like extensions, satellite lesions, immune ring of Wesley, that was there. Signs were more than the symptoms, वो था. Then viral में you are having the two things, herpes simplex, herpes zoster. Simplex is the simple, जिसमें we have dendritic keratitis. Dendritic keratitis means true dendrites when I have knobs, and steroids were contraindicated because it can hasten the formation of the amoeboid ulcer. On the other hand, the more severe is the herpes zoster. Zoster is the severe one, roller coaster ride. Zoster resembles the coaster. So roller coaster ride, it's a severe one. It resembles, it involves all the three divisions of trigeminal nerve, frontal, lacrimal, nasociliary. Strict one side distribution is there. And then we have the Hutcheson Rule also. We have pseudodendrites also. And the most characteristic is nummular keratitis. Clear hai? Now because here you have got the systemic features also, coin-shaped areas, exactly, because you are having the systemic features, so you will also give the systemic cyclovir here. Okay. Now if you talk about the Acanthamoeba, so the fourth kind of ulcer where you are getting the typical, this area, this is your ring infiltrate. Ring infiltrate is there. So if you are getting this typical ring infiltrate, especially in a person who is having the usage of the contact lenses. So first of all, if you are getting ring infiltrate, you are getting the history of contact lens use. Then if you are getting the history of trauma with the vegetative matter. If you are getting history of trauma with the vegetative matter. Now vegetative matter say we are confusing it with the fungal ulcer, because fungal ulcers are also caused due to the trauma with the vegetative matter, but here we will have to differentiate it. Similarly, if you can see the macrophages, now you can see macrophages here. Due to that you can confuse it with the bacterial. Now what are these macrophages? Actually these are not macrophages, these are the trophozoites. These are actually the trophozoites, which is the active stage. Trophozoites is the active stage of the amoeba, and they resemble the macrophages. Then we also get the pseudodendrites. They also get the pseudodendrites, due to which we are resembling it with the viral. So can you see we have a lot of complications. Sometimes they say that the history of trauma with the vegetative matter, due to which we are having confusion with the fungal. We can see macrophages, confusion with the bacterial. We are having pseudodendrites, confusion with the viral. So how to find out what type of ulcer is this? You can have growth. So you can see the growth on non-nutrient agar. Non-nutrient agar enriched with the E. coli. You can have a growth on the non-nutrient agar which is enriched with the E. coli, and then you are sure that this is a case of Acanthamoeba. Now, a characteristic feature. See, you will get a history of contact lens use. Plus, you will also get one more history in these patients, non-nutrient agar mein, pain which is out of proportion. Pain which is out of proportion to the size of the ulcer. If the pain is out of proportion, like bacterial were also very painful, but there the pain was in proportion to the size of ulcer. In fungal, painless था. Viral में क्या है? That we are having the decreased corneal sensations. Why we have decreased corneal sensations? Because virus go and they hide in the trigeminal ganglion. But यहाँ पर pain is more than the size of the ulcer. This is because of the radial keratoneuritis. This is because of the radial keratoneuritis. Radial arrangement जो है nerves का, there we are having inflammation. This is called as radial keratoneuritis. Lot of, yes. So, what is the most common infection? Yes, somebody has rightly written. What is actually the most common infection in a contact lens user? So when I talk about a contact lens user per se, the most common infection is Pseudomonas. While in Acanthamoeba, the most important risk factor is the use of contact lenses. So I hope the vision is very, very clear between all the four types of the ulcers, the layers of cornea, the properties of the cornea, and any kind of question related to these things will be very clear. One another important thing where we are talking about the non-infective ulcers. So one important thing where we are talking about the non-infective ulcer. Can you see? This is the keratoconus. Very, very important. Non-infective ulcer is the keratoconus. So, instead of the convex cornea, I am having the conical protrusion of the cornea. Okay? So, when I am having this, there is a increased axial length. Due to this increased axial length, I will have axial myopia in this patient. Very, very important है ना. Increased axial length हो गया and irregular भी है. So I will also have irregular astigmatism. I will also have the irregular astigmatism. So this patient will have increased axial length also, as well as irregular astigmatism. Very, very important thing. Now if you see this, tip of the cone at the slit lamp. So what you are going to see, you will see a oil droplet reflex. This is called as the oil droplet reflex. If you are seeing over the slit lamp, this tip of the cone is seen as a oil droplet. Sometimes it is, stretching. So again, Descemet's membrane rupture. So usse what we can have is the acute hydrops. The complication that I can... Do you remember what kind of striations we have in congenital glaucoma? I always tell you H for harp and H for horizontal, याद है. इसी तरह से here you have V for walked stria and V for vertical. V for walked and V for vertical stria we are having. So here I am having V for walked and V for vertical. ठीक है. तो मायोपिया हो गया, रिफ्रैक्टिव स्टेटस, एस्टिग्मेटिज्म हो गया, रिफ्लेक्स में ऑल ड्रॉपलेट रिफ्लेक्स हो गया, कॉम्प्लिकेशन इज द acute high drops, and V for walked and V for vertical. Now a very important sign. Can you see? When this patient is looking in the downward gaze, this cone is actually leading to downward turning. So there is a inferior, bulging of the eyelid when the patient is looking in this inferior direction, because the tip of the cone is actually indenting it. So this sign is actually called as Munson sign. This sign is called as Munson sign. So Munson sign is actually seen in the keratoconus. When the patient looks in the downward gaze, there is a localized indentation, localized bulging of the lower eyelid. This is called as Munson sign. Who will tell me the treatment of keratoconus now? And do we have similar thing in the lens also? Munson sign is there, yes. And what is the Fleischer's ring? One is KF ring and one is Fleischer's ring. Uska difference क्या है? One is your Fleischer ring. Here what you get is the Fleischer ring, and one more thing is the KF ring also. ठीक है? So basically Fleischer's ring is found in the keratoconus, while the KF ring is found in the Wilson's disease. Fleischer's ring is due to the iron deposition. KF ring is due to the copper deposition. ठीक है? So these two things are very, very important. The Fleischer's ring. Like one more thing is your Stocker's line. Last time I told you about Stocker's line. That is again very, very important. That was found in the pterygium. And again that was your iron deposition. So always remember these three things. Again very, very important. Fleischer's ring, KF ring, and the Stocker's line. Copper deposition is there in the KF ring. Iron deposition at the base of the cone we have. At the base of the cone, KF ring is due to the copper deposition found in the Wilson's disease, while Stocker's line is in the near the apex of the advancing head of the pterygium. That is again the iron deposition. So treatment. How can we treat the keratoconus? Treatment में we can give the contact lenses. Which type of contact lenses? Usually it is the rigid contact lenses. We have got the hard contact lenses also, soft contact lenses, and uske beech mein we have semi-soft or the rigid. So it is the rigid contact lenses usually which are the treatment of choice. Number 2, we can also give the riboflavin drops. Riboflavin drops we can give. These drops are actually to prevent the collagen cross-linking. To prevent the cross-linking, so that you can say to prevent the progression. How can we prevent the progression? By doing the collagen cross-linking. So they are cross-linking the collagen so that we do not have more of protrusion, so we can prevent the progression. And in the last, if I do not have any result, then we can do the corneal transplantation. So these are the important things that are asked about the keratoconus. So we have summarized the cornea. We have done with the pathophysiology, anatomy and physiology of cornea, the layers of the cornea, all the important questions over the cornea related to that. then corneal ulcers, infective corneal ulcers ki comparative analysis, and then this non-infective keratoconus. So if there is any query guys, you can ask me. Halbert-Streeter provisic bodies are the inclusion bodies. They were found in the trachoma. Can you explain the Rizzuti sign? Rizzuti sign is similar to the Munson sign only, guys. It is actually when you see over the slit lamp and you see that conical reflex over the slit lamp due to the stretching of the cornea, that is called as the Rizzuti sign. Next time I will show you the image also. Right now I am not having the image of Rizzuti sign, but I will show you. It is actually the corneal light reflex that you see in keratoconus, that is called as the Rizzuti sign. Okay. So guys, we have come up to the end of this session. I hope you enjoyed this session. You have understood all the comparisons between the different corneal layers as well as the different kind of corneal ulcers. So we have done with the conjunctiva and cornea. Please let me know what is the other topic that you want me to take next time. I know you were saying that take all the topics. What about the lens? Can we take lens? Because you know there are a lot of cataracts as well as the cataract surgeries. So I wanted to show you certain blades also that could be asked in your examination. So I think next time we will be having the image-based session on the lens. Till the time, I'll wait for your comments. How did you like the session? Anything extra that you want from our site? And what about the lens image-based session for the next time? Thank you guys. Keep studying and keep motivating others. Thank you and happy ophthalmology. Bye-bye.